esta mañana, que nos darán sus conocimientos y podemos aprovecharlos. Creo que es un privilegio poder contar con esta calidad de ponentes y participantes. Vamos a darle el tiempo al presidente del Colegio de Oftalmólogos del Estado de Sonora, el doctor Leonel Gutiérrez Mendívil, para que pueda hacer la oficial bienvenida a este webinar, Focal Points, para posteriormente tomar la palabra nuevamente un servidor y poder dar a conocer el programa y los currículums de la gente que nos acompaña. Muchas gracias. Adelante, Leonel.
Buen día a todos. Este es un webinar organizado por el Colegio de Oftalmólogos de Sonora, incorporados a la Sociedad Mexicana de Oftalmología, la sociedad médica más antigua en Latinoamérica, 126 años ya. Este colegio está integrado a la sociedad y este webinar está avalado por el Consejo Mexicano de Oftalmología. Agradecemos al doctor Humberto Ruiz Orozco, presidente del Consejo Mexicano, a la doctora Leslie Farrell, y también agradecemos a la presidenta de la Sociedad Mexicana de Oftalmología, la doctora Claudia Palacios, y a su vicepresidenta, la doctora Irma Zamudio. Este webinar está transmitiéndose directamente a través del canal de YouTube del Colegio de Oftalmólogos de Sonora y quedará grabado para posteriormente poderlo revisar. Y pues quisiera yo darle las gracias a nuestros ponentes. Les agradecemos mucho su tiempo, el esfuerzo que han hecho. Tenemos grandes personalidades, el doctor Samuel Basket, la doctora Nicola Fram y el doctor Carlos Guillermo Arce. La verdad, les agradecemos mucho su presencia y su participación. Y sin más, pues empecemos. Abraham, pues empecemos a la presentación, por favor, de los currículums de los ponentes, si son tan amables.
Bien. ¿Se ve mi pantalla?
Perfecto.
¿Correcto?
Sí.
Muy bien.
Muy bien. Les damos una cordial bienvenida a nombre del Colegio de Oftalmólogos del Estado de Sonora a este webinar de Focal Points. Aspectos técnicos del webinar. Este webinar es transmitido por la plataforma de Zoom. Para que su recepción sea de calidad, deberá liberar su banda ancha de Internet, desconectando sus dispositivos como teléfonos celulares y otros para mejorar la calidad de audio y video. Este webinar cuenta con la opción de selección de lenguaje de acuerdo a su preferencia. Contamos con servicio de traducción simultánea de inglés a español. Deberán seleccionar el icono de mundo y después el canal de idioma de su preferencia, ya sea español o inglés. Los requerimientos técnicos necesarios para una buena experiencia de este webinar requieren 3 megabytes por segundo de subida y 20 megabytes por segundo de bajada. La forma de liberar la banda de ancha y lograr estos objetivos es desconectando sus dispositivos como lo expuse anteriormente. Les invitamos a formular sus preguntas en el icono de preguntas y respuestas. Este será el lugar en donde sus preguntas podrán ser consideradas para preguntarse a los maestros. Estas pueden ser formuladas en español o en inglés a los profesores invitados. El examen de evaluación del Consejo Mexicano de Oftalmología con validación de 3 puntos para este webinar aparecerá a la clausura del evento. Ahí lo podrán resolver y enviarlo a la dirección que se les indicará más adelante. También será enviado a los correos electrónicos para que pueda ser llenado y enviado a las direcciones de correo que se indicarán también más adelante. Recordamos que la acreditación de los puntos de consejo se otorgará para todos los que participen vía Zoom. Se extenderá una constancia de asistencia a todos los participantes a este evento del Colegio de Oftalmólogos del Estado de Sonora que se hayan inscrito y permanezcan en el evento. Esta transmisión también es realizada directamente a YouTube en el lugar del Colegio de Oftalmólogos de Sonora. Los objetivos del webinar son conocer los principios de la selección de lentes intraoculares basado en Total Power Wavefront de Galilei 6. 2. Evaluar técnicas de cirugía de catarata en ojos complejos. Y 3. Conocer el estado actual de las dysphotopsias. Nos acompañan como moderadores y traductores el doctor Sergio Ruiz Esmejao y la doctora Tamara Montenegro Tapia, ambos especialistas en segmento anterior, egresados de la Asociación para Evitar la Ceguera en México. Y como coordinadores del evento, el doctor Leonel Gutiérrez Mendívil, presidente del colegio, y un servidor, doctora Remedia Martínez, como coordinador de este webinar. Un agradecimiento especial al doctor Luis Lu de Arizona, que nos apoyó para poder realizar este evento. El programa será el siguiente. En primer lugar, participará el doctor Carlos Guillermo Arce de Brasil con el tema IOL Selection Based in Total Corneal Wavefront from Galilei. Él hizo su fellowship en el Departamento de Oftalmología de la Universidad de Florida con el doctor Frank Pollack. Es especialista en oftalmología por el Consejo Federal de Medicina del Brasil y el Consejo Brasileño de Oftalmología. Colabora desde hace más de 18 años con los sectores de bioingeniería ocular y óptica refractiva de la EPM y de la Unifest. Y actualmente es jefe del sector de tecnología e investigación del Hospital Oftalmológico y Bancos de Ojos de Sorocaba. La doctora Nicole Fram nos hablará de cirugía de catarata y de catarata en ojos complejos. Ella tiene el certificado en oftalmología con expertise en cirugía refractiva y cirugía compleja de catarata, segmento anterior y reconstrucción y trasplantes corneales. Ella es manager del Advanced Vision Care en Los Ángeles, California. Es instructora clínica de oftalmología del Stein Eye Institute de la UCLA y ha recibido su grado médico del Thomas Jefferson University. Ella es chair de la Academia Americana de Oftalmología y miembro del Comité de Catarata y sirve como editorialista del Journal de Catarata y Cirugía Refractiva. Y por último, el doctor Samuel Masket, que nos hablará acerca de dysphotopsias. No requiere presentación, es una de las mayores autoridades a nivel mundial en el tema. Él se desempeña como profesor del Stein Eye Institute y Jeffers School de Medicina de la UCLA, Los Ángeles, California. Es una de las máximas autoridades en este tema de dysphotopsias. Sus aportaciones a la literatura mundial son muy importantes y tenemos el placer de tenerlo esta mañana con nosotros. Ese será el orden que llevaremos esta mañana en las presentaciones. Muy bien. Pues damos el tiempo esta mañana para la presentación del doctor Carlos Guillermo Arce. Le pedimos que pueda compartir su pantalla e iniciar su presentación. Y una vez que finalice su presentación, le pediremos dejar de compartir para que la doctora Frank pueda iniciar su participación. Gracias y adelante.
¿Puedo comenzar?
Adelante, sí. Perfecta el video y audio. Adelante.
Okay, I have to go very fast because I think I put too many slides. It's not going on. Okay, my financial disclosure. How sphericity is represented? By the BFA or best fit A sphere or the best fit toric aspheric elevation maps? By the epsilon square or by the Q factor? or by the spherical aberration? This is a question I used to do to my residents, and the maps are the graphic representation of asphericity. The asphericity of the corneal surface is the Q factor, which is different sign of epsilon square, which is called eccentricity. And the spherical aberration is actually the sphericity of the wavefront. So an spherical surface has epsilon square 0. Central curvature is the same than peripheral curvature, and peripheral light rays focus in front of the central rays. So spherical aberration in this case should be around 0.28, 0.30 microns, positive. However, corneal surface used to be aspheric. And aspheric means that the central curvature is different than peripheral. It may be prolate when center is steeper, or it may be oblate when center is flatter. When normal prolate surface gets around 0.6 epsilon square, light rays crossing the center at center focus close to peripheral light rays. It means the Sturm conoid and the point of less confusion is very small, then spherical aberration tends to be close to 0. When an aspheric surface has epsilon square more than 1 or equal than 1, it is already a hyperprolate surface. And 1 means a parabol. From 0 to 1 means an ellipsoid. And remember, 0 is an sphere. So peripheral light rays will focus behind the central light rays. Then the spherical aberration will be negative. In oblate surfaces, after myopic LASIK, for example, peripheral light rays focus in the front of central rays. Therefore, the spherical aberration is positive, more positive than what is normal. Most normal corneas are from spherical to ideally prolate with a spherical aberration. It means between 0 and 0.3. Initial ectasia of keratoconus suspects used to have an epsilon square more than 0.6, and corneas with keratoconus already have hyperprolate anterior and posterior surfaces with the epsilon square more than 1, and therefore they used to have negative spherical aberration. So in the Galilei, the spherical aberration is here in the 4th line at the center. So normal corneas, as I told you, used to have between 0 and 0.3. But the spherical aberration of the eye increases during life due to the length, the changes at the length. The cornea will remain stable if there is not deformation. If the cornea begins to deform, then the spherical aberration of the whole eye also changes. So when the cataract comes, all the spherical aberration internal from the lens is gone. So the addition of the IOL plus the cornea will be the result. So remembering, cornea becomes more prolate, the Q factor and epsilon square increases, so the spherical aberration becomes less positive or even negative, okay? And when the cornea becomes less prolate or more oblate, the Q factor and epsilon square is reduced, so spherical aberration becomes more positive in microns. Okay, and the spherical aberration and shape has very good relation, as you can see here in these graphics, for the anterior surface and the posterior surface. These are very old, has almost 10 years already from a work we presented in the World Congress in Boston and in Paris in the ECRS. So IOL spherical aberration must match the total corneal spherical aberration and not the whole eye spherical aberration, because the lens internal, the natural lens is gone. So the IOL presently available are or spherical, it means between 0.25 to 0.3 microns, aspherical neutral with a spherical aberration 0 or neutral, and an aspheric negative with different negativity. So this is the type of IOLs we have available. Total corneal aberrometry is what the cataract surgeon needs then. So for example, in this cornea, it's normal. You can see that it has only 0.21, and we have different kind of IOLs available. Which one will be better for this normal cornea? The spherical positive? Yes, why not? Maybe you want to do monovision in that eye, so you increase a little bit, 0.25 plus 21. It's not exactly that addition, but let's say that you get 0.4. And with a positive spherical aberration, you are going to have much better vision with less addition. Okay, but if you want to maintain that spherical aberration, you can implant an aspheric neutral. Or if you want to compensate, so you can implant a negative spherical aberration IOL. So this eye will get very close to 0. So this is the case, for example, that if you want monovision, let's say in the left eye, okay, you can implant a neutral or a positive spherical IOL. And for the eye for far, you can implant negative aspheric IOL. What happened in post-myopia? You can see here it has plus 94. So in this eye, you cannot implant a positive spherical aberration IOL because you are going to increase too much the spherical aberration, but still you can maintain in neutral, or you can reduce that spherical aberration implanting a negative. And what happened after post-hyperopic LASIK? In this case, we have minus 0.81. So in these cases, with keratoconus, pellucid, or after hyperopic LASIK, you cannot implant the negative spherical aberration IOL because you are going to induce more negative spherical aberration. So the reasoning is the opposite. But the second aberration we have is the coma. And the coma, we use a limit of 0.5 microns of coma in 6 millimeter aligned to pupil. Okay, and the coma is in the third line in the vertical coma at the left and horizontal coma at the right. So we have also the coma that can be in diopters. To understand coma, we have to understand the elevation maps. While the BFS or best fit sphere compares the cornea against an ideal sphere, is at the two maps at the left, anterior and posterior. And in these maps, what is the number we have to see? The maximum BFS. What is the maximum BFS? Is the peak of the mountain. the sphere we have, and the cone or the cornea is matching that sphere. So if you have 1 here in the number in the map, you have 1 micron more than the best fit sphere in curvature. But if you have minus 20, you are going to have 20 microns less than the best fit sphere. That's what means here, this kind of maps. So there's representation we have here that I used to call the fried egg sunny side pattern, okay, is showing us here at the center the peak of the mountain, okay? But in best fit toric aspheric, we compare the cornea against an ellipsoid, a perfect ellipsoid, and you can see that the center is 0. So the center is the best fit sphere. The best fit sphere is converted to 0, and then is the difference in different meridians, in all meridians, okay, the representation of where is the cornea. So if in the center is 0, I have one depressed meridian and one elevated, one in blue, one in yellow. So thus we are observing the belly of the shape at the bottom, as we can see here in the image at the right, like your mouse and your computer has actually this kind of pattern. In these maps, we don't need to see the maximum value because it's some kind of bias, okay? What we see, what we measure here is the difference between the more depressed in blue and the more elevated in white, in yellow, sorry, in yellow. So this index, this differential index in the BFTA maps was called by me Kranemann-Arce index, and that was in 2009. Okay, very old index right now. And when we have a map completely green, we don't have asymmetry. When we have one blue, one yellow, then we already have around 20 microns difference. 2 blues, 2 yellows will be around 30 microns difference. In the Galilei, everything is color code because the scale is 5 microns. The relation between the Kranemann-Arce index anterior, AKAI, or posterior, with the comma is very good, especially in the anterior surface. So approximately, when you have 0.5 comma, you already have 20 microns of asymmetry. So one blue, one yellow means already approximately 0.5 microns of comma, which is our limit of normality, approximately. Okay. Remember that the posterior KAI, posterior Kranemann-Arce index, was called in 2013 as AAI, Aspheric Asymmetric Index, okay, by David Smadja and collaborators as a predictor of keratoconus. Okay, the normal cornea is, and the comma in general, especially the vertical, is linked to the keratoconus progression. And comma means, of course, dispersion of light rise. So my question is, how much corneal comma or asymmetry in surfaces we may tolerate without symptoms when asymmetric premium IOL is implanted? Okay, something happened. Okay. Now we have another two aberrations, trefoil and quadrifoil. We use 0.4 and 0.3. So trefoil is in the third line and quadrifoil is in the fourth line. And it happens that when the corneas are very asymmetric or wrinkled, irregular, folded, okay, remember two letters. Letter S as a sinusoid shape of the surface, depressed at the top and protruded or ectasic at the bottom. This is the typical shape, for example, of pellucid marginal degeneration, and is usual also after refractive surgery when ectasia begins. And remember the other shape, the other letter M, as in mama. Okay, this is produced, for example, in radial keratotomy, because there is an elbow of incisions. After transplant, PKP, because these sutures and the graft and the cornea has also an elbow. After intracorneal rings, especially the larger rings, 310, 320, you don't have that in States, but we have in South America and the rest of the world. Okay, this kind of shapes, S or M, increase incredible the trefoil and the quadrifoil. Okay, so observe the map in BFTA. The map begins to be irregular. It's blue, yellow, green, blue, yellow, and we don't have actually a pattern. Okay, like in keratoconus when there is a very clear asymmetry. And this is because the surface is undulated, waved, okay? It's green, yellow, green, blue, green, yellow, is waved. So in this case, for example, we have irregular patterns, and this is a Fuchs. You have this kind of a very thick cornea with, in densitometry, we have the double peak here. You can see it in the arrow, double peak, because the endothelium doesn't have a dispersion of light rays, and this was called the camel sign, 2 hubs. And this is typical when we have Fuchs or Gutata. And you can see the different aberrations we have. So when diffractive IOLs should not be implanted? Well, actually, we don't know how much trefoil, quadrifoil, fifth order these IOLs may produce, because they have prisms here. Okay, we know that when the IOLs is dislocated off center or tilted, the IOL will produce coma. Actually, one of the questions I used to have is spherical IOLs or aspheric IOLs will produce more aberrations. Spherical IOLs, if they are tilted, for example, they remain spherical, they remain the same surface. But if the aspheric IOL, which are prolate, becomes to be tilted, look what happened. So the prolate or hyperprolate surface will produce more coma than spherical IOLs. So if you have an eye, for example, with weak zonula, I rather to implant an spherical IOL, because if it's dislocated or tilted, it will produce less aberrations than the aspheric neutral or the aspheric negative spherical aberration IOL. Okay, so should we implant in corneas with asymmetric or irregular surface? My answer is very clear, no. So I use these numbers, okay, that are usually related with different pathology, and I recommend to use third, fourth order in order to choose the best patient, not only because he's a lawyer or very I will say, delicate person. No, it's more because the cornea should not have 0.5 comma, 0.4 trefoil, 0.3 quadrifoil, and fifth order 0.2. Actually, fifth to sixth to seventh order is more related with the quality of surface if the surface is very rugose and is usually affected by tear film. So if we put a good lubricant, fifth to sixth to seventh order aberrations will use to be reduced. Be caution when kappa distance is larger, okay? And the second, in the time I have, the second concept I want to introduce you is about the total corneal power. How the corneal power is measured? By the keratometry? Yes, this has more than 100 years. It's more than 100 years technology, okay, with keratometry. By corneal topography, it's more recently. It have around 30 years right now. So we have flat keratometry, steep keratometry, and SIMK, which is the median or average between flat and steep. Okay, and this usually is measured in the central 4 millimeters of the cornea. So we use this simple formula for mirrors, K and 2 and 1 and radial of curvature in meters, okay, in order to convert these millimeters of radius in diopters. And thanks to Alvar Gullstrand, who won the Nobel Prize for this, we got a keratometric index. This was simple because 45 diopters corresponds to 7.5 millimeters of radius. The error will be 1, so the only number we didn't know if the refractive index, the assumed refractive index of the cornea, which would be 13375. This is what Gullstrand found, and we also call Gullstrand index. So, but we can, in the Galilei, not only have the Gullstrand index, we also may have the map in the real physiological index, which is 1.33376. So if we use the Gullstrand index, we are going to have 43.38, okay? And this is in diopters. In millimeters of radius will be curvature, but in diopters will be curvature? No, it is the assumed power of the cornea, but only with anterior surface data. In order to have curvature in diopters, we must use the physiological index 1376. So Gullstrand was very happy and very lucky when he did his research, because without knowing the thickness of the cornea, without knowing nothing about the posterior surface, he got a number of power for assume the cornea, the whole cornea, only with the anterior surface. there is not only way to calculate the total corneal power. First, I want to show this using the physiological refractive index. And you can see that there is not 4338 as we had before. We would have 48.33. This is the curvature in diopters. 4338 is the assumed power only with data from the anterior surface. So there is a so-called true net power, okay, which is actually only the addition of anterior plus posterior curvature. Okay, so it's not true because it's only anterior and posterior, nothing about the thickness, and it's not power because it's the addition of anterior curvature positive and posterior curvature, which is negative. Okay, so in this special case, when we have a hyperprolate posterior surface, you can see here 189 for the posterior surface. So, but the anterior is with 47.5 minus 605. The true net power in this special cornea will be 4145 and not the 4338 that is assumed by the Goldstrand index. As you can see, there is a large difference in true net power in this cornea. But we also may have what is called the equivalent power of the cornea, which in Orbiscan was called before total mean power. Total mean power uses the thick length formula, including the thickness here and the physiological refractive index. So if we do this, we are going to get 4362. So this is much closer to what the SIM-K is and not the true net power. Farther than this, we have the total corneal power by ray tracing. This is different. We are going to calculate by Descartes' Snell law how is the incidence of the light rays in the anterior surface, what happens when cross the cornea, and what happens when leave the cornea going to aqueous humor, which is media with less refractive index than the cornea. So the light rays cross from the air in one, then gets the cornea, who has 1376, and then gets the aqueous humor in 1336. So if the light ray in the anterior surface converges because the refractive index is higher, is a more dense media, so the light rays breaks a little, the speed of the light ray breaks a little, the light rays converges. But when it's getting the aqueous humor, it diverges a little bit. This is what we learned by ray tracing. And this is probably the best way to get the power of the cornea. In the Orbiscan was usually called total optical power. And in the Galilei is called total corneal power. Total corneal power, or TCP. So, and we may have a mean TCP, which is the median between the flat and the steep TCP. Okay, so, and we also have the central TCP, which is the mean of all dots, all measuring dots within 4 millimeters diameter. Okay, so we have different corneal powers measured: SIM-K, true net power, total mean power, mean TCP, central mean TCP. Okay, and these are normal for normal corneas, but with in corneas with refractive surgery, my suggestion since 2003 already, is a long time already, okay, and it was published in Archives of Ophthalmology. Our paper about this is to use the total corneal power. From all this total corneal power, I used to do the mean TCP or the flat and steep TCP for toric IOLs, and the central mean TCP in 4 millimeters for aspheric, monofocal, okay, in corneas with refractive surgery. Presently, we also increased the corneas that we do this, corneas with rings, corneas modified, and corneas with radial keratotomy, corneas with keratoconus grade 2, grade 3, or further. Grade 1 keratoconus may still probably do with SIM-K. And this is related also with the posterior-anterior relation, okay, because remember that the posterior surface used to be steeper and more hyperprolate than the anterior, so changing the relation between curvature in the anterior and posterior. You can see here the total corneal power in this eye, which had refractive surgery. And there is a simple trick here. If you use the peripheral value 4176 minus the central value 3624, you are going to have here approximately 5.5, and this number will represent, especially if you have a small optical zone, okay, you are more or less have the amount of surgery the patient had. So I want to show you this kind of maps, TCPs, okay, because many people don't understand these maps and don't know how to interpret them. We may have maps with very few color steps. This is typical of corneas that are spherical monofocal. But if you have a bow tie like this, remember blue is less power and yellow will be more power. So this is a kind of oblate cornea, okay? You have a toric cornea, but it's still with very little steps, very little number of steps, it tends to be monofocal. And you may have very clear multifocal, either spherical or toric, as we are going to see, when you begin to have this kind of concentric steps of colors, very clear here. This is a multifocal cornea. Remember how the IOLs are always. You have toric multifocal, skewed toric multifocal like this at the top, or even post-LASIK in this case with decentration. You see, off-center, asymmetric treatment in this case is right eye and left eye of a very good friend of mine, okay, that I discovered this with the Galilei and told him that that's the reason he has difficulties to drive at night, etc. But these are a kind of multifocal corneas with off-center multifocality. Okay, as you can see, we found with the Galilei very curious cornea that tends to be monofocal at the center, but multifocal to the top. This is very common after patients who use soft contact lenses long time, and and have beginning to have neovessels in the limbus. Or you have horizontal nasal to less power, okay? This might be after pterygium, or when kappa distance is very dislocated. This map is centered here to the Purkinje, and this little cross here is the center of the pupil. So when this distance between the two is too large, we may have also an horizontal multifocality, okay? We have this kind of vertical multifocality, but going to less power. So this meridian will be prolate, okay? And the comma, you see that the belly used to be at the top. Why I show this cornea? Because it's totally against what we see with the classical asymmetry, with the classical asymmetry that happens in keratoconus. In keratoconus, we are going to see what I call the multifocal channel, like in the glasses. People with more than 40 used to use the multifocal glasses. So we have these different steps to the bottom. We may have this in normal corneas, but in early PMD, as you can see here, or in keratoconus, in very advanced keratoconus, this is very, very clear and with much more red colors at the bottom. And this is a sign, probably I will publish soon, of keratoconus or corneas that tends to be keratoconus. But what happened with very irregular corneas? This is a patient with Fuchs, and there's at the bottom are corneas with advanced keratoconus, even with scars or things like that. So what is the first map I see if I want to implant a multifocal IOL? The best fit thoracospheric in order to see if I have coma. But even in that kind of eye with some, for example, 20 or 30 microns of Kranemann Arce index in the front surface, okay? So around 0.5 comma, maybe I still can implant a multifocal. Maybe not. I used to be very conservative. But the second and probably very clear map, either to explain the patient, is the total corneal power map. Are you going to implant a multifocal IOL with concentric multifocality here? Remember, the IOL has to match the optics of this cornea. So it's very clear why we should not implant this kind of IOL. So I'm going fast in the 2 minutes I have because Abraham gave me 40 minutes. Thank you very much. Okay, about this point about IOLs, premium IOLs toric. So the alignment of the IOL is very important, and we have to understand what is the kappa distance, okay? Is related with the kappa angle, okay? But it's much better to talk kappa distance. We have the first Purkinje, which is the center of the 4 dots reflected in the cornea, the center of the pupil, okay, actually it's a centroid. If the pupil dilates, this point may change of position. So there is a relation between the kappa and the center of the IOL. The IOL can be misaligned. So if the kappa distance, it means the line of vision with the Purkinje and the pupil center, which is probably the place where the IOL will center in the middle of the back, inside the back, the capsular back, because a pupil is more anatomical. Maybe the center of the white to white would be, or the limbus will be much better. But we have kappa distance as the difference or distance between the Purkinje and pupil. So how much diameter has diffractive IOL? The most common use in South America, for example, has 0.9 millimeters of diameter. So if you have a kappa distance of 0.45 and the IOL aligned to the pupil, because it's the center of the back, the line of vision will cross the first ring. So our limit for this kind of IOLs should be around 0.45 millimeters. And for refractive IOLs you don't have in the United States, like the Reiner, you only have the Bausch and Lomb, I think. Maybe I am wrong, but we also have Reiner from England. The first ring has a larger diameter, so we still can go to 0.75 millimeters. This misaligned IOLs will produce coma and bad quality of vision. So I want to explain this with only one case. Observe this man who had 65 years old and had PKP, penetrating keratoplasty. This multifocal toric total corneal power map shows you that it has astigmatism with the rule anterior and posterior surface. So if it has parallel with the rule anterior and posterior, the anterior astigmatism is 3.83. The posterior is minus 0.76, okay, and the total corneal astigmatism is posterior is subtracting, so it has a little less than the anterior. But please observe something very important. Not only that the total corneal astigmatism is less than the anterior, but also that the axis of both cylinders are very, very close, as we are going to show. Okay, so this is a special case. I will ask everybody, are you going to implant the multifocal IOL here? Observe the multifocality at the top, probably related with the incision, the limit of the graft, okay? Observe this. This is the data of wavefront alignment to pupil, and almost all the devices has alignment to pupil, okay? And you have 0.8 vertical coma, 0.58 horizontal coma you have here in diopters, and you see the axis of the coma, okay, is totally different, is oblique, and totally different than the axis of the cylinder. But what happens if I align to the, what should be here, oh, excuse me, okay, this is the spherical aberration, 0.7 negative in diopters and 0.91 in microns, okay? Remember then that we have to compensate this high spherical aberration. So probably a good IOL for here will be a negative spherical aberration IOL, but multifocal, toric, or monofocal. Okay, we implanted a toric monofocal IOL with 0.27 microns of spherical aberration. Observe also that this eye had fifth and sixth order, and so we had to lubricate very well this eye in order to see better. Okay, but now I will align to white. Galilei is probably the only one, the only device that we can change the alignment from pupil, like everybody has, to limbus or white to white, and observe the axis of the comma now. Okay, and it has very close to with the rule. Look, the vertical comma decrease it, but the horizontal comma increase it a lot here. And the spherical aberration changed and it was reduced. Okay, we told you that the white to white probably is more related because it's anatomical to the center of the back. So if the IOL would center to the back, look, the spherical aberration is much less than alignment to pupil as we assume it. And this is only in 6 millimeters. We also can change this spherical aberration and this aberration like comma with less diameter, because your capsulorhexis is 4 or 5 millimeters. We can match even to the size of the diameter of the pupil. And what happened with the line of vision when it's aligned to the first Purkinje? My comma increased a little, but the axis is still horizontal, very close to what is the axis of the cylinder, and my spherical aberration is very close also to the white to white. So in this case, we have a very happy patient. We didn't do a multifocal, okay, but we implant a toric monofocal because the axis in the first Purkinje and the white to white of the comma was very close to the axis of the cylinder, despite the comma is a little larger than 0.5. Okay, I think I don't have time enough to talk the rest, okay, but the only message from the rest that I want to tell you is that normal corneas may have change of 10 degrees of more in the axis of the cylinder if you align the data to the Purkinje or to the pupil. And when there is asymmetric corneas, like in keratoconus, 38% of the corneas will change the axis of the sync, the anterior cylinder. This happened in the posterior surface, and this also happened in the total corneal power cylinder, okay, where almost 5% of corneas will have, normal corneas will have more than 10 degrees switch of axis between Purkinje and pupil alignment, okay? So that is very clear that we must use the same alignment we use for marking for our toric, and the same alignment we have from our device, okay, to implant the IOL. If one device tells you that the alignment is to the apex and you don't know where is the apex in the cornea under the microscope, or the vertex, you don't know where is the vertex under the microscope in the surgical field. So you have to use data aligned to pupil, to Purkinje, or even to white, because that's what you are going to use in your surgical field or in the slit lamp when you mark for the toric implantation. Okay, so please remember always, okay, how marriage is decided in some countries. Okay, and this I learned it when I went to India. They say that there's arranged marriage, but this arranged marriage is related with the horoscope. They make the horoscope of the lady and the man. If this horoscope matches with each other, then they promote the marriage. That's the reason I used to say that the Galilei is the horoscope of the perfect marriage between the cornea and the IOL. Thank you very much, and I'm sorry for the long time I take in this lecture. It's in English.
Excelente
Spanish
presentación, Carlos, ha sido magnífica, muy clara, y te agradecemos por esta presentación. Vamos a final, te invitamos a que estés con nosotros en el módulo de preguntas y respuestas para hacer temas de discusión y generar y desahogar las preguntas que se prepararon para ti. Gracias. A continuación vamos a dar tiempo a la doctora Nicole Frank, por favor, con su charla del día de hoy. Bienvenida y gracias. Adelante. Si gustas compartir pantalla, Nicole.
Okay, thank you so much. I appreciate being here. It was a wonderful, comprehensive lecture. I learned so much, and I'm hoping to talk to you all today about the appropriate patient selection and preoperative considerations in the trifocal patient. And I think what's most important is that we need to know how to make an educated decision, and a thorough history and diagnostics and imaging is extremely important, as was pointed out in our previous lecture. But I think experience and judgment is something that we also really need to consider. I think that many people, when they're trying to decide whether to put a bifocal or trifocal lens in, feel that personality match is appropriate. And there's definitely this gut feeling that you have when you approach a patient of how meticulous they are. So if they come in with 4 pages of questions, you may want to take a pause and kind of talk to them about the limitations of the technology. But I do think that if someone is educated and they understand some of the side effect profiles, that they'll do very well with this technology. Night driving is a question that I always ask. If somebody drives a lot at night with certain trifocal and bifocal lenses, they may experience a lot of halo and glare. And I think that this is one of the most important things that you want to ask these patients. But I think in the end, we have a responsibility to these patients, and we must understand that these multifocal and trifocal lenses will give you some glare and halo at night. And the patients that we see in our practice that are unhappy after surgery can have a variety of reasons why, and you need to investigate these things carefully. Now, this is a slide that I borrowed from mi jefe, Sam Maskett. And I think it's really important to take the time in all patients to look at the cornea and look for keratopathy, evaluate these opathies. So look for pupillopathy, maculopathy, and optic neuropathy, but also look at psychopathy. If a patient cannot understand what we're telling them about the side effect profile of these lenses, then they probably should not have these lenses implanted. So one of the things that we always start with is ocular surface considerations. If you don't look at the cornea, you will get burned in these cases. And many times patients are already dilated, they have dilating drops in, you go in and their surface is not ideal. And you think to yourself, well, maybe it's just the dilating drops that are causing all this severe dryness. In Los Angeles, California, there is a lot of interesting eyelid surgery where sometimes patients can't even close their eyelids. And this becomes a huge problem. So if you don't look at how patients blink and how they lubricate their ocular surface, you will run into trouble with these lenses. Other times, you wait for the fluorescein to go away and you say, is that the tear breakup time? No, that's actually epithelial basement membrane dystrophy. And we're going to talk about a case of how we want to treat this. And then next, you may ask yourself, why did I lift that eyelid? If I just stayed in denial and I didn't lift their eyelid, I wouldn't have seen this scarring. And you can see how these nodules and lumps and bumps on the cornea, I'll show you in a moment, can affect your surgery. So this is a case of a 65-year-old plastic surgeon who had decreased vision. He wanted to get back to operating in 1 week. And we see this topography, and really looking at the placido imaging and looking at the quality of the placido imaging is critical. And what you'll see here is that the placido imaging has an irregularity within the first 5 rings. And so if you see irregularity within the first 5 rings, you put the fluorescein in and you let it wait, and settle for about a minute or two. Then it becomes obvious that this patient has epithelial basement membrane dystrophy, also referred as MAP dot dystrophy or anterior basement membrane dystrophy. But the issue is when you see these patients, your heart kind of breaks, because you're like, your road to cataract surgery and recovery is going to be a little bit slower than all of your friends. And the question, we all ask ourselves is, do I really need to scrape, or I like to call it polishing, the cornea? So pre-superficial keratectomy, you can see here that the cylinder was recording at least 2 diopters, and he wanted a 20 diopter lens. And then post-superficial keratectomy, we have a different lens power and only a 3/4 of a diopter of cylinder. We're showing this video here where what you're seeing is originally in the video, I'm going to take this back just a little bit here. We're going to put OcuCoat on the surface. So I've already done a superficial keratectomy. It's 8 weeks now after I've done the superficial keratectomy to make sure you get proper measurements. And then we're just going to go ahead and protect that cornea with methylcellulose, or you can use another dispersive viscoelastic. We'll do our surgery, we do our intraoperative aberrometry, make sure we clean the lens epithelial cells so we don't get capsular phimosis. This is a toric lens, so we want to go underneath the lens, get all the viscoelastic out to make sure it doesn't rotate over time. And then we go ahead and after the surgery, we put on a bandage contact lens. And we're putting on this bandage contact lens because we're using all of these drops. There's air conditioning in the room. We don't want the cornea to break down after we've done our surgery. And so these are the techniques that we've adopted that help us when we're doing these kinds of surgery. This is another case of a patient who came to me, and the referring doctor recommended a toric lens. And what you'll see in this placido imaging here is that there's irregularity, and there's flattening and then steepening. And yes, you have a bow tie, but it's an asymmetric bow tie. And then when you lift that lid, you see that there is actually a Salzmann's nodule. When you see this Salzmann's nodule, you may think, oh, it's in the periphery, it's not causing problems. But after we performed the superficial keratectomy, so before we have a pre-op topography of 5 diopters of astigmatism, and after we only have 3/4 of a diopter of astigmatism. When I take the Salzmann's nodules off, we often use mitomycin C, as Chris Rapuano from Will's Eye has shown, to decrease the incidence. So here I just wanted to show our technique of removing the epithelium, and we remove that with a Took knife, or you can use any sort of knife, but make sure it's at a 45-degree angle so you're not making nicks into the stroma. Then in addition, we want to peel that Salzmann's nodule off. This is often my favorite part of the procedure. And we go ahead and peel that off. Then we're going to use just a diamond burr to roughen up and create a Velcro effect for that. She had epithelial basement membrane dystrophy and a Salzmann's nodule. Then we'll apply mitomycin 0.02% for 20 seconds. And then we'll go ahead and rinse so that there's no mitomycin on the surface or causing problems with the stem cells. And then I like to use a self-retaining amniotic membrane. We found in our practice that decreases the amount of haze postoperatively that you can see. So this is extremely useful to do for these patients. So we went over epithelial basement membrane dystrophy. We went over looking at dry eye and looking at the eyelids, making sure that there's no Salzmann's nodules, and using your topography and your placido imaging to help you with these cases. The next thing I want to get into, and this is part of the previous discussion, which is, can we use these premium IOLs in patients after LASIK or PRK? And I think that we're under this pressure cooker of expectations of these patients. You know, after they had their LASIK or their RK, hopefully they were happy with their surgery. 96% are within 2020 after LASIK. And now we have to now do cataract surgery and reach those goals. And it can often be very, very disconcerting. We spent a lot of time in the previous lecture talking about the spherical aberration and the myopic ablation pattern, which will lead to positive aberration. So you may want to select a lens that has negative spherical aberration. And then there's this hyperopic ablation pattern that induces negative spherical aberration. So a positive spherical aberration IOL that you choose, or even a zero spherical aberration, may be better. So I think that lecture was very comprehensive and excellent at pointing out our lens selection. But some things seem like a good idea at the time, and they're just not. So, you know, we can look at a post-LASIK topography and say, okay, this is well-centered. There's some, you know, artifact in the center, but maybe this is a good candidate for a multifocal. They come in pressuring us. I want to have distance and near after surgery, and you can't let them dictate, patients dictate the best choice for their outcomes. Here, this is a little bit more obvious, where we have decentered ablation and a very flat cornea. This patient is not going to do well with a multifocal or trifocal lens. And then sometimes we fail even though we have the best intentions. So these are all patients that had relatively regular placido imaging, well-centered ablations, and they all failed. And so considering the spherical aberration pattern and looking at coma and looking at higher order aberrations may be what we need to do to get better outcomes in this patient population. And in fact, we looked at our multifocal IOL exchange, and Steve Nades, who's our associate in our practice, looked at 34 eyes between 2012 and 2017. And what we found was 30% had macular disease, such as epiretinal membrane, that was not diagnosed previously. 23% had corneal disease, whether it was EBMD, dry eye, Salzmann's nodules, but 47% had no comorbidities. And so this is the hardest part. And one of the things that I have adopted over the years is that when I talk to a patient about a trifocal, I'm so excited to offer this technology. But what I tell them is that 1 to 3% of patients are not going to tolerate the technology. And what you have to do is ask them to be on the journey with you. And if they can't tolerate it, if you say to them, I will help you, I will take the lens out, I will replace it with a monofocal, we can consider mini monovision, it takes the pressure off. And the patient then understands, I want to try this lens, but it may be that has to come out. And so I think if you're going to put these lenses in, you have to know how to take them out. Angle kappa and angle alpha were referred to in the previous lecture. Angle kappa is the difference between the pupil center and the visual axis. Angle alpha is the difference between the limbus center and the visual axis. And we try again to look at literature and look at cases to see if these things correlate with who is going to do well after a trifocal lens with these different predisposing measurements. And so what you can see a lot of the time is a high angle kappa and angle alpha may not be the best candidate for a trifocal lens. But you can have patients with a normal angle kappa and a normal angle alpha, and they do well after surgery. So when I talk to our colleagues, you know, they've looked at, Ike Ahmed and his colleagues have looked at over 3,000 cases, and they just can't find a consistent correlation. So I think one of the most important things is learning how to center these lenses and making sure that at least you're going to be centered on the visual axis, which was mentioned in the previous lecture and is so accurate. So we put this lens in. We want to go behind the lens and make sure we get all the viscoelastic out so we don't expect any shifting later. And then what we'll do is on the Lumera Zeiss microscope, you can turn off the tangential, and then you're just going to have the coaxial. And you want to ask the patient to look in the center of the two lights. And if those centers are within the center ring, you're going to have excellent centration and outcome. This becomes a little bit more difficult when you're trying to actually center a astigmatism trifocal lens. But nonetheless, you want to look at the visual axis, look at those Purkinje images, and make sure that we can get them centered with the coaxial light. And that's improved outcomes significantly. But when we look at higher order aberrations and angle kappa, I think you can find just as many articles saying that they're important and then saying that they don't really matter. But I think the consensus is that we really want to look at these higher order aberrations. And when we use our technology, so this is the iTrace technology, which uses ray tracing to do a wavefront analysis, the higher order aberrations should be less than 0.5 microns. And our cutoff for coma in our practice is less than 0.3 microns. And so here we have a patient with normal wavefront higher order aberrations, and we have a patient here with abnormal, but both did well after a trifocal lens. So that's where that conversation about if you're having trouble after surgery, I will help you comes in. So I think our take-home points, from dealing with patients, who is the right patient for a trifocal is meticulous preoperative ocular surface analysis. If I see a lot of dry eye after dilation and I'm examining the patient, I ask them to come back for their preoperative appointment, and I also look at their surface, and I will take the time to treat their ocular surface before we get to surgery. Then we get to surgery. Well, now you have a bigger job, which is maintaining that ocular surface. So you can't just do the surgery and give up on the patient. After that, you still have to maintain that surface for the trifocal to perform over time. We want to use topography, tomography, and wavefront technology to screen these patients. And what we're seeing in our practice is that coma is the best predictor of who's going to do well. So if you see a lot of coma, we don't want to use this lens in these patients. We want to adopt a new technology to find the right technology. So whether it's the Galilei or whether it's the iTrace, find a wavefront aberrometer that works in your practice so that you can evaluate these things. Be very cautious in patients that have irregular corneas, such as post-LASIK. And if you can put it in, you need to know how to take it out. So I wanted to show a case here of an IOL exchange with an opening in the posterior capsule. One of the most frustrating things that we hear in our practice is that the doctor told the patient that because someone opened the capsule, they can never take the lens out. Now, it's true you have to adopt the right skill set and stay in your lane. And if you don't have confidence taking these lenses out, you can find someone who knows how to do it, or you could develop the skill over time. And I want to just take you through how to do this kind of case when the posterior capsule is open. So here we're just taking viscoelastic and viscodissecting under the anterior capsule. When you see these kind of lenses, so the Technis platform lens, they tend to get caught up at the optic haptic junction, whereas the Alcon lenses will get caught up at the terminal bulb. And what we're doing here is we're lifting up rather than rotating, and we're going down the optic haptic junction and using a second instrument to kind of slide that optic out of the capsule bag, but lifting up the whole time. One of the things you want to be careful of is you don't want to overfill the chamber, because then that will extend your posterior capsule opening. So we're lifting up and then rotating. And so we can see we can get this capsule, this lens out nicely and keep the capsule intact. Next, we're going to take serrated microsurgical forceps and a 19 gauge scissor. This is MST technology here. And you're actually pulling towards you as you're cutting. You're watching the capsule bag and you're watching the iris to not cut those things. Then we're going to, this is a 2.4 millimeter incision, but you can make it 3.0. You don't want to fight with the cornea. Use a second instrument to block that haptic as you're pulling it out. And you just can pull out slowly and re-grab and make sure the haptic doesn't hit the cornea. And then we go ahead and rotate that half, and then we go ahead and pull it out. Now the whole time we want to make sure that the chamber is formed, that there's enough viscoelastic, because it's the hypotony that will cause the vitreous to come forward. We found that the Bausch & Lomb Softport LI61AO is a wonderful lens to use in these cases where their corneas are abnormal. It has zero spherical aberration, and it's a silicone lens. So it's very friendly in the eye. And what we're going to do in this case is we put the whole thing in the sulcus, and then we perform optic capture. We don't leave lenses in the sulcus secondarily because they tend to move over time. So you either want to do an optic capture or you want to suture it to the iris. I always put in preservative-free triamcinolone to make sure there's no vitreous prolapse. And then we'll go ahead and put a miotic in and make sure that every time you come out of the eye, you're filling with a viscoelastic or BSS to make sure that the chamber doesn't collapse. And using subconjunctival dexamethasone makes the eyes very quiet the next day. So the moral of this story is we want to use the technology of trifocal, but we need to be very careful in patients that have problems with their cornea ocular surface and in patients that have had LASIK, whether it's myopic or hyperopic LASIK, to make sure that they don't have a lot of higher order aberrations. So next, we're going to get into cataract surgery in corneal disease and keratoconus and RK in particular. I think with keratoconus, it was pointed out that sometimes you don't know where they're looking through their cornea. And so it's very hard to figure out the corneal apex. What we need to make an educated decision, again, is this thorough history. So do they wear contact lenses? Will they wear a contact lens after surgery? If that's the case, then spectacle independence is not your goal, and they can go ahead and have a monofocal and use a scleral lens after surgery. The diagnostics and imaging and consistency is critical, and this experience and judgment, which we talked about earlier. I think it's all about the IOL selection in these cases, understanding, how contact lens dependent they are and stability of the cornea. Have they had cross-linking where UV light is applied to the cornea with riboflavin to strengthen the cornea? How long do you wait after cross-linking to know they're stable? I don't think anyone clearly knows the answer on that. Optical status of the fellow eye. So are they spectacally independent in the other eye, or will they need intervention in the other eye is extremely important. And if you do see astigmatism that's reproducible across many devices, can we use a toric? And we're going to get into a case like that in just a moment. Considerations for EDOF lenses or trifocal lenses in mild keratoconus should be considered. But we know from the work of Sumitra Kandawal and Doug Koch that the steeper the cornea, the greater the hyperopic error. So all of us have put in lenses in a keratoconic patient and then had a hyperopic surprise. And this graph here gives us a reason of maybe why it's happening and maybe a rough nomogram of how much myopia to add to the case to kind of do an adjustment. So you'll see once you get into the 48 or 49 diopter, effective diopter range, you want to consider adding IOL power to make a myopic outcome to get to your distance goal. And then the steeper the posterior cornea, the greater the hyperopic shift. So using technology and tomography that can measure the posterior cornea, it's the same idea. Once you get past 7.5, 7.0, you really want to add some lens power to these cases and go from there. So one of the things that you need to do when you start off with these patients is to make sure that you tell them, I'm going to do the best I can. And if you wear a contact lens and you're happy to wear one after, the easiest thing to do is to put in a monofocal. If you're going to go down the road of putting in a toric, you want to make sure that the patient understands that there may need an IOL exchange after surgery, and or that you have to have a great relationship with an optometrist that knows how to fit bitoric hard contact lenses if the patient cannot go under exchange for whatever reason. So the first question I always ask the patient or I look at is, what is the patient wearing in their glasses? So we can see here there's 2 diopters of a stable refraction that is about at 170 degrees. And we'll see on this topography, we have 2 diopters at 170. So our anterior topography from our atlas shows that. Then we look at our IOL Master 700, we have 3 diopters, but at the same axis. And then we look at our lens star, and it's similar to the IOL Master. So the question I would ask is, would we use a toric in this patient? Well, this patient doesn't wear contacts, has no interest in wearing contacts, has a clear cornea, so they're not a candidate for any sort of corneal transplantation. There's no scarring. So if you use a toric, then how do you aim the sphere? And, you know, we look at this and we say, okay, within the central 3 rings of the placido imaging, we have consistent measurement here. So we want this concentric symmetric bow tie in that 3 millimeter zone. And so the plan is in this patient is to target a -2 sphere. And the reason why I did that was because we had a 49, 48 diopter cornea at the steepest point. So we went for it and we planned a T6 and we planned a 12.5 diopter lens at an axis where 3 machines were telling me to do it. And what happened was at postoperative week 2, postoperative week 2, the patient was 2100 and we had this hyperopic, unpredictable shift. We did well with the astigmatism. And so what do? So in this case, we had to offer an IOL exchange and we needed to do a shortcut. So the Gills and Hoffer shortcut is for a hyperopic outcome. You can do 1.5 times the spherical equivalent, which was 1.75. And we had to add approximately 2.5 diopters or 3 diopters to this patient. So we went ahead and did that. And so the plan was to add a 15.5 diopter T6. And what we're doing in this case is we're lifting up rather than rotating. And we're going to bisect this lens similar to the case we just showed previously with the 19 gauge scissors. And we're going to take this out. Go ahead and open up the whole capsule to the equator. So before you put the lens in, you want to make sure you put a spatula and make sure the whole lens is open, lens capsule is open. We're going to go underneath once again to make sure there's no remaining viscoelastic that could lead to a problem with rotation of the lens. And we're going to rotate this lens on the axis that was reliable and consistent even after surgery. And the case finishes up nicely. Now, post IOL exchange, we have a 20/25 outcome with a very small refractive error, but it looks like we didn't hit our targets and we tried to use all the technology to get there. And that's where having the relationship with the patient and the patient understanding that there will be IOL exchange that'll be imminent in their future possibly is really important. So let's get into a radial keratotomy. We see a fair amount of radial keratotomy in our practice, and it is the gift that keeps on giving. So they have fluctuations throughout the day. There's a hyperopic progression. There's AM to PM fluctuation that is not always predictable, and the calculations are not always predictable. And these hyperopic surprises are very disconcerting for the patient. The other difficult part is that it's hard to obtain the flattest case. And so we try and use all these technologies to get there, and it's difficult because of the fluctuations. We can add IOL power to compensate for these hyperopic shifts. But there's caution when you use this with intraoperative aberrometry as the pressure in the eye is changing and changing the curvature of the cornea. And so we don't recommend using intraoperative aberrometry in these cases. In addition, with toric IOLs, there's extreme caution with the usage and reliability after surgery. And then the most important thing is when you're doing this cataract surgery, you want to avoid any transection with the RK cuts and to expect there will be a transient postoperative hyperopic shift. Now, when I joined Dr. Maskett, I said, how do you calculate these lenses? And he has this Maskett voodoo nomogram that I've kind of developed to help him over time, but this has not been published, and it is useful as a gross measure. If the RK cuts are about 4, we add for an aim of minus 0.75. If they're 8, minus 125 to minus 150, 12 minus 175, 16 minus 2, and any more than that, all bets are off. Good luck. The longer the cuts and the smaller the zone, the optical zone, the more power you want to add in these cases. But let's look at the literature. What's out there in the literature? Well, Graham Barrett and colleagues looked at this in 52 eyes and found that the Barrett True-K with history resulted in 75% within a half a diopter. And Higas found the same thing. But there are big limitations to the study where they only looked at 8-cut RK and they measured 4 to 6 weeks postoperatively, which there can be fluctuations after that. In our practice, when we look at our data, we hit our target about 65 to 70% of the time. So I think if we can get in the range of 75%, I think our patients would be ecstatic. Here are the technologies that we use and the nomograms that we use in formulas. It's the Barrett True-K formula, in addition to the ASCRS calculator formula, where you can put in a number of measures to help with reliability. But especially in this patient population, you must tell them that they may need an IOL exchange. Now, what you see here is that I'm marking the areas of the RK incisions to make sure that throughout the case, if I lose visualization, I understand where these incisions are and to not bisect them by making paracentesis in that area or an incision. You want to stain with trypan blue because you want to make sure that you have complete visualization, because sometimes as the corneal incisions hydrate, you lose visualization. Any RK incisions greater than 8, I will go ahead and do a scleral tunnel incision, and it can be, right behind the limbus, but you must be, within these RK incisions if you want to go clear corneal, and just go scleral tunnel if you can't tell or can't visualize. And you can see here, initiating your capsulorhexis is much easier as you go throughout the case because you have the trypan blue staining. And we go ahead and make our curvilinear capsulorhexis in the normal fashion. But what happens is once you start this case, you're going to start to lose visualization. And people say, I don't understand why you need the trypan blue. But if anyone does these cases on a regular basis, you'll notice this. Now, this patient also had a little bit of zonulopathy. So instead of rotating the lens, I want to pick the pieces up and bring them to me. And so you can just kind of chop in that fashion and bring up the heminucleus. And then we went ahead and polished the anterior capsule and put the lens in the normal fashion that you would throughout a case. And so the case finishes up nicely. I knew exactly where to put my incisions. I knew exactly how to not get into trouble in terms of bisecting these RK incisions. Now, what the patient needs to expect after is that there's going to be a hyperopic shift. So you have to counsel them that they're not going to be perfect after surgery by any means. And if they are perfect after surgery, that's actually not a good sign when you have greater than 8-cut RK. We want to prevent these pressure elevations. So I'll often give patients a diuretic like Diamox to help them after surgery so that we don't have a lot of pressure on our corneal incisions if they're fragile. But postoperatively, we need to wait for stability of the topography. So approximately 2 months after surgery, depending on the number of cuts, we want the preoperative topography to match the postoperative topography. And that's when you know you've hit your refractive goal. And we want to be prepared and have the patient prepared for IOL exchange if it's necessary. Often you say this once and you think the patient understands. You have to kind of repeat yourself and help the patient understand that they don't have a normal eye and that you'll help them get to the point where they want to be. Now, maybe technology can help us. So this is a patient, this is eye trace technology, a patient that came in with a mild cataract. And you can see in the first image, you see a blurred E and the topography underneath. And this, it looks like a highly irregular cornea consistent with RK incisions. The central E shows a blur zone that is consistent with the cataract that's developed. But if you look at the total eye, so the total wavefront, the E looks pretty good. So you have a patient that comes in and they're 20/30, 20/40, the cataract's not that bad. You want to be very careful, because if you take that lens out, that lens that's been compensating for their coma and compensating for their trefoil, you can actually make them worse. So we want to wait for the cataract to become much more significant in this kind of patient before we proceed. So having a large degree of patience for this population is important, and not rushing into cataract surgery, because sometimes you do the surgery and they say, well, I was better before the surgery than after. And it's because we don't have lens technology that can actually match their cornea. We don't have this wavefront guided IOLs that can go in and match their posterior and anterior cornea. So it's extremely important to be cautious. Now there's small aperture technology. So the Trindade pinhole aperture lens is very exciting in patients that have highly aberrated corneas. And so this is a technology that we don't have available in the States, but you probably do. There's also the IC8. We were part of the AcuFocus trial. You've probably had this for some time. And we think that that's where the application of this IOL will be best fit in our post-RK or keratoconus patients that would do well with small aperture technology to decrease on the higher order aberrations. So the take-home points is that the patient must be counseled at length. You have to take the time. You can't kind of give this to a surgical tech to do. I think we need to be prepared to do IOL exchange. The formulas and diagnostics are definitely improving, and whether or not we need corneal cross-linking to stabilize these patients before is in the literature, and we're trying to figure out. The pinhole technology, I think, is going to be a lifesaver in a lot of patients with highly aberrated corneas that are not amendable to penetrating keratoplasty. And then we've just adopted the light adjustable lens to help us hit our targets. They'll have to stay in their UV protected glasses for much longer until the cornea stabilizes. But will our targets be more reliable? That's what we want to figure out. So I thank you all for listening to me today and inviting me to be here.
Congratulations.
Excelente presentación, Nicole. Muchas gracias. Muy brillante exposición. Vamos a continuar y te invitamos, Nicole, a participar en la mesa redonda en unos momentos más. Gracias. Doctor Másquez, vamos a presentarlo el día de hoy. Es para nosotros un honor tenerlo aquí en el Colegio de Oftalmólogos del Estado de Sonora. Sabemos que es un experto en el tema de dysphotopsias y estamos aquí para escucharle. El tiempo es para usted. Si gusta compartir pantalla y adelante con su presentación. Muchas gracias.
So, are you seeing my screen?
No, no yet.
Okay, let's try that again. Let's see.
Okay, it's correct.
You're seeing me now, yes?
Yes. Please, full screen, select. Gracias.
So, good morning or good afternoon, buenos días, buenas tardes. Lo siento mucho, es necesario hablar inglés. I'm going to talk about a subject that is sometimes very difficult for ophthalmologists, called pseudophakic dysphotopsia. I do have some disclosures, but I don't think they're necessarily relevant this morning. What the dysphotopsia condition represents is an undesired subjective photic phenomenon that the patient observes. And what makes it difficult for the patient is that it is associated with otherwise uncomplicated cataract surgery. That's really how we define these dysphotopsias. So we do what we are told is a perfect anatomic job. The eye looks beautiful, and the patient may have any of these phenomena. We define them as positive dysphotopsia because what they see there are actual light forms. They may come as light streaks, more typically arcs, central light flashes, starbursts. And this can come from any intraocular lens and can definitely interfere with patient function. Negative dysphotopsia, on the other hand, is a peripheral darkening, kind of like wearing horse blinders. And we call it negative because there is no light. In fact, it's dark, and it looks like a temporal dark shadow. And then any of the diffractive multifocals can also give us what we call a diffractive optic dysphotopsia, and those are usually manifest as halos, rings, or spider webs. All of these have a little bit different etiology. And because the etiology differs, actually patients can have all three of them, despite what we think is perfect anatomic surgery. Diffractive optic dysphotopsia, I think, is very easy to understand. It comes from the diffractive rings and the separation of light energy. So we don't really have to belabor that in our conversation today. But positive and negative have been a little bit less easy to understand. So I'll try and take you through them and what we have done to manage them in our practice. The incidence is actually much higher than you think. And in fact, Randy Olson in his presentations and publications has taught us that it is the chief cause of dissatisfaction in otherwise routine surgery. And in a paper from his department, where in fact they defined the term, they found that as many as almost half the patients at some time after surgery will have some type of dysphotopsia. That may be a little bit high. Other papers have shown the incidence less, born us 19.5%. Interestingly, when we look at purely negative dysphotopsia, there are two good studies out there that'll tell us somewhere between 15 and almost 20% of patients will have negative dysphotopsia early after surgery. Fortunately, those numbers decline over time. There is neuroadaptation to negative dysphotopsia, so that at about a year, it's down to about 3%, maybe 2% at 2 years. But just due to the large number of cases, somewhere 15 to 18 million cases of cataract globally annually, you're looking at maybe 500,000 or more people who will have chronic negative dysphotopsia. So this is indeed a problem. In fact, it has reached the attention of the FDA. I happen to have the privilege of chairing a committee for the first time that includes representatives of the FDA, the IOL manufacturers, the American Academy of Ophthalmology, and UCLA Rand Corporation, who are all of us are combined making a patient-reported outcome measure, or what we call a PROM, that will become part of the evaluation for premium IOLs in the future. That is, we want to hear from patients. What are they seeing? And in fact, this is in a trial right now. 600 and some patients are participating. And one of the panelists, Scott McRae, has had his department, University of Rochester, make references that help patients understand the different forms of dysphotopsia. So here is a street scene in Rochester, New York. It's on a cloudy day, midday, and this is what it would look like to a normal view. However, if patients who have glare in a variety of forms, snowballs, starbursts, streaks, halos around lights, they might notice this. It's a little bit difficult to depict positive dysphotopsia because it has movement associated with it. But it's this white arc that is depicted here, and negative dysphotopsia is depicted as this temporal dark arc on the outer side here of the left eye. Interestingly, though, here they show it as a kind of a simple comma. What we've come to learn, and which I'll show you subsequently, is that with both eyes open, the temporal defect is much larger than with one eye open. And so that's why it's a little bit difficult to depict it. And the some of the diffractive lenses, particularly the EDOF version, is characterized by these spider webs seen around point sources of light. So we're using this in helping us develop this patient-reported outcome measure. Let's talk about the dysphotopsias as they are, and we'll concentrate on the positives and the negatives. And interestingly, there's a disconnect between these two. Most people try to lump them, but with positive dysphotopsia, I think we have a better understanding of this condition. There's a clear correlation between what the optical lab or the bench tells us and what the clinical findings are. It turns out that it's related primarily to square edge design and high index of refraction, which also translates into increased surface reflectivity. The position of the lens doesn't seem to matter, whether the lens is in the bag, sulcus, or what have you. We don't have ways of measuring it. We only have patient-reported outcomes. And there doesn't seem to be the CNS component of neuroadaptation. On the other hand, with negative dysphotopsia, there's a poor correlation to some extent between what we see in the bench, the optical lab, and the clinical findings, so that we're getting better there. The other thing is that ND seems to be induced by any IOL, irrespective of index of refraction and edge design. But the IOL position seems to be a very important factor, and that is, if it's in the capsule bag, it's possible. If the lens is out of the bag, it's most likely not going to happen. Again, patient-reported outcomes help us understand, but we also have learned that we can use Goldman visual fields in the far periphery to evaluate negative dysphotopsia. And there is a CNS component, and we'll talk more about that later. And as I mentioned earlier, there's a neuroadaptation to this phenomenon where it tends to improve over time. Slide is not advancing. Oh, okay. Let's talk about edge-induced positive dysphotopsia. This was first reported actually by me in a multi-centered study. What we learned in the early 1990s, this goes back obviously some time, before we were using foldable lenses, the company started to truncate round lenses to reduce the diameter so that we could implant them through smaller incisions. But what we learned is that this truncated or square edge became associated with these undesired optical phenomena or edge reflection. And when we subjected these lenses to this reflectometry, we found that we would get this spike of oblique light hitting this edge, reflecting back onto the retina. We reported that in 1993, and subsequently during that next decade, a large number of papers all came out in the Journal of Cataract and Refractive Surgery looking at the square edge as inducing positive dysphotopsia. And so one might say, well, why don't we just get rid of the square edge? Well, the square edge is here to stay for quite some time because it definitely inhibits or retards the progression of PCO. And this brilliant work from Nishi, what he had the manufacturers actually make square edge design for him in PMMA and also in silicone IOLs. And he found that this bending angle here at the square edge of the IOL prevented these LECs from moving on to the posterior capsule. And here's a wonderful example of an Acrosoft lens. You see all of this, these pearls on the capsule outside of the lens edge. But once you have the lens edge that blocks it, posterior capsule is clear. In fact, in the beginning, most people thought the Acrosoft material itself was responsible for preventing the PCO, but the Acrosoft was actually the first IOL out there with the square edge. There seems to be another cause as well of positive dysphotopsia. Jay Erie published in a few papers that if you have a very flat anterior surface with a high index of refraction and the power curve on the back of the lens, you would get these internal reflections off the back surface of the front of the lens that could give you central light flashes. So we've come to understand that positive dysphotopsia is most likely due to square edge design and high index of refraction IOLs. In our practice, we have found that we can manage some patients medically by making the pupil smaller, either with brimonidine or by pilocarpine. But if that fails, the patient is terribly symptomatic, then this lens has to be removed and replaced by one of a different material because we can't offer them one without a square edge, as there are none on the market presently in the United States other than large 7mm PMMA lenses. And this information will be coming out in this year. It's been accepted for publication in the JCRS. In this study, what we've looked at is the IOLs that are responsible for the PD, and we found that roughly 80% of them are hydrophobic acrylic IOLs, as you see in this pie chart. What lenses do we use to help them? Well, if the inciting IOL is indeed a high index of refraction acrylic lens, we have found that the lower indices of refraction are in silicone lenses or in a copolymer IOL. Unfortunately, not all of these lenses are any longer available to us. Our go-to lens was the Star Surgical 1.41 index of refraction round edge three-piece lens. It's been removed from the market by Star, as has their three-piece Collamer lens. So presently today, our IOL of choice is the Bausch & Lomb LI61 with a 1.43 index of refraction. Unfortunately, though, still has a square edge. Here's a case, and Nicole showed one earlier, a dissatisfied multifocal patient. Here's a patient, and again, the surgeon opened the posterior capsule thinking that that would help positive dysphotopsia, which is a folly in my view. This is an older video before we had the valved trocar system. But almost invariably with an open posterior capsule, you will need to deal with the vitreous. So I placed the trocar thinking that I might need to do that. This is a spatula designed by Eric Donenfeld, used for femtosecond laser. We get under the edge between the anterior capsule and the surface of the optic. And I have found that when the posterior capsule is open, it's even more difficult to remove these lenses. This is the now J&J, or the original Technis AMO lens. And as Nicole indicated, there is this waste here at the loop optic junction that often forms a fibrotic ring, making it difficult to remove. So rather than fight with it and do greater damage to the zonule, in that situation, I will cut the loop optic junction, and then I'll use the same 19 gauge she showed to cut the optic in two pieces and remove it. Now, if you can use the anterior capsule for optic capture, I will, unless subsequently, as you'll see, we're dealing with negative dysphotopsia. This is a lens, unfortunately, no longer available. This is that Star Surgical three-piece silicone IOL that had a round edge, a 6.3 millimeter optic, and was our go-to for dealing with patients with positive dysphotopsia. And as Nicole mentioned, if you cannot use optic capture, in our practice, we don't believe in just passive sulcus fixation because lenses tend to move. So I'm going to use a 10-0 polypropylene suture to sew the loops of the lens to the peripheral iris, and we'll sew them in mechanical fashion, and then make certain that the pupil is round by teasing the iris toward the center if necessary. You want to be as peripheral as you can with these suture bites, and you really only need 1 millimeter to 1.5 millimeters. If they're peripheral and they're not too wide, you're going to have less of a likelihood of creating a cat's eye. And if there is any vitreous, of course, you want to stain it with triamcinolone. Here, fortunately, we did not have to deal with any. We set pressure at physiologic levels. We make sure that all incisions are watertight. So here, even with open capsules, yes, we will exchange a lens if a patient is significantly symptomatic, but we encourage surgeons not to open the capsule thinking it's going to help positive dysphotopsia. If PD has been there from day one, then it's not going to be due to the capsule. If PD evolves later on, and then the capsule is a possibility, then it might be okay to open it. Negative dysphotopsia, as I mentioned, however, is a temporal dark arc. Jim Davison was the one who coined the term in a publication back in 2000. And this has been an enigma ever since. So 20 years in, we still don't know all the things we need to know about it. Jack Holliday has worked mostly in the lab using ray tracing. And his initial publications indicated that the square edge design and high index of refraction, just like in PD, was likely the cause. As we'll see subsequently, it turns out not to be the case. And the work that Nicole and I have done, we've actually found that it's irrespective of the lens material and design, but more the relationship of the IOL to the capsule bag, as we will subsequently see. And there, I mentioned there's a disconnect in ND between the lab and the clinical findings. Again, initially the lab said that the high index and square edge IOLs were causal. We found that any lens will do that. ND was also in the lab associated with a greater iris to IOL distance, that is an expanded posterior chamber depth. We have published, as has Vamosi and Benjamin and Burke, that that's not the case. And ND was allegedly not associated with round edge IOLs, but we have subsequently found that that's not the case at all, and the posterior chamber depth is just not a factor. Looking at Holliday's original work from 2012, he developed what he calls this type 4 shadow based upon ray tracing that would not exist with a round edge. More recently, though, Jay Erie, Michael Simpson, and others using ray tracing have developed the theory of an illumination gap as being causal of ND. And that is that oblique light coming across the pupil will miss anterior to the optic, and there will be the anterior edge of the rays missing it. Then the rays hit the optic and are refracted. And so between the anterior rays and the refracted rays, there is a gap. And this illumination gap is theoretically associated or causal of ND. And it seems very plausible, but as we'll see subsequently, unfortunately, it doesn't answer all of the questions. One is an example, if we had a thicker lens, we should have a greater illumination gap, but that turns out not to be the case. Interestingly, also, ND is greater in left eyes than right eyes, greater in women than in men, and that is not, unfortunately, explained in the lab. In a paper that Nicole and I published, and we are very, very proud that it was voted by the editors of the JCRS to be the best paper of 2018, and we received the Oakspam Award for that. Looking at IOLs in particular, we found that 73% of the IOLs were hydrophobic acrylic, 23% were silicone, and 4% hydrophilic acrylic in 40 IOLs that required removal for chronic ND. Interestingly, this represents basically what is the market share of lenses in the United States. And with regard to the silicone IOLs, 12.8 or 13% of all of the IOLs in this study turned out to be round-edged. So I think that clearly takes away the concept that high index of refraction, square edge IOL is associated. So why is there this disconnect? Why is the incidence greater?
Which is the difference between Pentacam and Galilei technology?
I'm sorry, I don't understand. Is there a question for me?
No, so, por el momento, puede continuar.
No, okay. Go ahead, Dr. Muscat.
I'm sorry. So why is there a greater incidence in women than men? Why is the incidence not 100% if that illumination gap is true? And what's the difference between acute and chronic ND? Is that where the CNS comes into place? Evaluating patient complaints with ND has been difficult. Just like in PD, we don't have a machine, so to speak, or a dysphotometer, where we can put a patient in this machine and we can measure their scotomas and what have you. And typically, people use Humphrey visual fields to try and measure. And of course, it's not going to work because the Humphrey visual field at best can only go out to 60 degrees, but these peripheral scotomas exceed 70, even 80 degrees. So Goldman kinetic visual fields are potentially more helpful. And in fact, Rudy Noit's group in the Netherlands published on this. Natalia Mahatkaina has published on this several times. And they were able to demonstrate that you can use the Goldman kinetic mode in peripheral visual testing to look at changes. They found some generalized constriction. They find this temporal arc as is typically described. And we use the Hogstride Octopus 900 to also try to ascertain what's going on with these patients. And as you can see here, we were able to measure in one patient this temporal, mostly infratemporal arc inside these red lines that define the scotoma. Interestingly, though, and very interestingly to us, and opened up a whole new area of study for us, in our practice, we use this partially opaque patch, actually designed by my wife, for visual field analysis. And when we put this on the patients to do these visual field studies, we were surprised that 80% of them said, just, you know, when I put this cover over my eye, it makes the ND better. We thought it had something to do with this partially opaque patch. So when we put the pirate patch on top of that, patients actually noted a greater improvement. And we had between 50 and 95% subjective improvement in the negative dysphotopsia when we covered the fellow eye to do the visual field. We tried this in patients who had normalized and patients who had visual field defects from other causes and didn't find it. We found this to be really interesting, and we didn't know what we were looking at. So here again, if we take a look at this paper, the red scotoma is with the partially opaque patch. Then we put the black patch on top of that. The defect was smaller and more peripheral and less bothersome, and we did publish this, in fact. So we thought, well, if they get better when we cover the fellow eye, maybe we can use this for occlusion therapy to enhance their neuroadaptation. So we actually did part-time, fully opaque patching of the contralateral eye. We did this for about 10 patients. They did notice improvement only when it was covered, though. We didn't get a lasting effect. And of course, it wasn't really well tolerated. People don't like to walk around, they lose their depth perception. So then we said, well, maybe we should put, since we know most people think that ND is stimulated by temporal light, well, how about if we put a partially opaque contact lens on that blocks light in the coming from the temporal periphery? Will we make them better? And in fact, we did get a therapeutic response, but again, poor tolerance. People don't like these lenses. They're thick, and they can also induce their own visual field defect. But it opened up a whole new world for us because we were, for the first time, able to understand why patients were seemingly so symptomatic with ND, with both eyes open. So here, and for some reason the other field is not coming on, what we did, we put patient behind the Goldman perimeter. We did binocular visual field, and we found this very, very, very large scotoma, understanding why patient would be symptomatic. I'm going to try and bring this up again. For some reason, this other field is not showing, but I'll show you another example. Here is a patient where this is the entire scotoma with both eyes open. We put then the peripheral contact, this is a left eye. We put the peripherally opaque contact lens on their right eye, and the scotoma was then reduced to this size here. Even more dramatically, look at this patient. Here, with both eyes open, the right eye, the ND, occupies this entire area here. But when we cover the fellow eye with the peripherally opaque contact lens, it's a very, very small line. So this tells us why the ND patient is so much more symptomatic than we think they would be when we're doing monocular visual field testing. This has not held up with patients who have neurologic causes for visual field defects or glaucomatous. The other thing that's more interesting is that patients who are truly monocular have never been reported to have negative dysphotopsia. So this brings up the central nervous system as being part of this condition. We can measure a scotoma with kinetic perimetry. It improves with contralateral occlusion. Over time, most patients improve. So we intend to study this with functional MRI studies. Actually, our fellow Zsofia Rupnik is now back home in Hungary, and she'll be doing those studies there. But let's move back now to the clinical manifestations of ND and what we've learned and what we can do to help patients. The final common pathway in our experience is any IOL that's in the capsule bag with this overlying anterior capsulotomy, particularly on the nasal side. If instead the optic is anterior to the capsule, whether it's in the sulcus or whether we have anteroplaced or done reverse optic capture, that is bringing the optic edge over the capsule, then their symptoms are going to be relieved, prevented, or improved. And our corrective surgery is based upon that. So optic anterior to the capsule reduces the symptoms. Optic behind the capsule allows the symptoms to occur. This is the clinical correlation. Nasal capsule over the lens, you can get ND. Lens over the nasal capsule will prevent it or improve it. And some people have actually gone ahead and removed the nasal capsule by laser and improved. In their studies, 5 of 6 patients were improved by doing that alone. And taking this one step further, in just a one case report in the literature, Alipati removed the nasal aspect of an IOL, leaving the capsule intact, and alleviated the symptoms. I wouldn't suggest doing this at home. From our paper, we did 58 procedures for patients with chronic ND. Some of them were therapeutic, that is, people who were symptomatic, or the others were preventative, second eyes. And what we found that is when we brought the optic over the capsule, either as a therapeutic method or as a preventative method in second eyes, 42 out of 43 eyes were successful in preventing, improving, or eliminating ND. It also seems that if you put a piggyback lens on top, you'll have improvement in about 75%. If you take a lens out of the bag and put it in the sulcus, we've actually had nearly 100% improvement. But if you do a bag-to-bag exchange, as some people have said will work, our experience is negative, 0 of 4. We no longer recommend that at all. So lens has to be on top of the capsule to eliminate ND. And here's what this looks like. So here, following removal of the cataract, we're polishing the capsule and subcapsular cells extensively to try and reduce phimosis. This is that Li61 lens that we mentioned before. We remove all of the OVD from behind the lens, but put some on top of it to cushion it. We lift the edge and grab it with a 2 MST forcep, and then pop the optic anterior to the capsule, leaving the loops in the bag. Now, when we do this primarily, we still get rapid fibrotic PCO, and in all the patients for whom we've done this, we've had to open the capsules by 3 months postoperatively. So the patients need to be aware of that. As the lens is slightly anteroplaced, we will get a little bit of a myopic shift, and the high power lens, you want to plan accordingly in selecting your IOL power. And note, you will get these stria in the capsule with a 3-piece IOL. There are, however, some negative consequences to this strategy. Again, I mentioned the PCO very rapidly, but also lenses in the sulcus over a long period of time may shift or may induce some pigment dispersion. So in order to mimic the reverse optic capture, or having the optic anterior to the capsule while leaving most of it in the bag, I designed an anti-dysphotopic IOL that features this groove to receive the anterior capsulotomy, leaving the rest of the bulk of the lens in the bag. This has been published in Expert Review of Ophthalmology. And in fact, Morcher has made this for me in Germany. You can see here in the schematic, this is the groove that accepts the capsulotomy. And if you center the capsulotomy on the visual axis, you're going to have just perfect centration of the IOL which, as we'll see subsequently, brings some additional advantages to it. We've done this in clinical trials in Europe. 175 lenses have been implanted, the bulk of them by Peter Vamishy and Tobias Neuhan. None of the 175 lenses have had negative dysphotopsia. We've not seen iris chafe. There are 2 other lenses in Europe that are designed to have capsule fixation of the IOL. That is the bag and the lens from Marie-José Tassignon. And thousands of these cases have done, not one has been reported to have ND. And the Femtis IOL, which also is anterior capsule fixated, in a study done by Gerd Aufarth, none have had ND. And a recently published paper from Versace with this lens, none have had ND. So we've learned clearly that if you have the optic edge over the anterior capsule, you eliminate ND. There's so many more advantages to this capsulotomy supported IOL. A more predictable ELP, stable toric axis, it cannot rotate, cannot have capsule contraction. You'll have perfect centration, particularly if you put the center of the capsulotomy on the visual axis, reduced higher order aberrations, and limited tilt. Of course, this mandates a perfect or near perfect anterior capsulotomy, either automated by femtosecond laser or other device, or guided either by the Callisto or other methods. In this one case, Lukan Mishev in Sofia, Bulgaria, using the Hogstrite eye suite, did a morture of my design, capsule supported, and found that he had essentially no change in the anterior chamber depth over a 30-day period. And that's in distinction to a standard in the bag IOL. So the ND enigma goes on. It's more than just a shadow. We know that we think that there's a central nervous system contribution to it. We think that we can help some people with occlusion. It is measurable with kinetic perimetry. It's a fascinating subject, but unfortunately frustrating to surgeons and patients alike. I think we need to be very, very sensitive to the patient's complaints. We need to explain to them as best we can what the condition is, that most often they will note improvement with it, but that if it fails to improve over time, we can move that optic anterior to the capsule, we can piggyback them, or we can exchange it for a sulcus lens. So I thank you for your attention to this subject this morning. I know it's been a late morning for all of us, and I'm really very happy to have been part of it today with you. And I really appreciate what I learned from the other speakers. So thank you for having me.
Congratulations, Dr. Musket. It was a very nice presentation.
Muy bien, doctor Musket, le agradecemos mucho su participación, una magnífica presentación. Excelente presentación. Vamos a pedirle, por favor, al doctor Arce y a la doctora Frank que puedan integrar para la mesa de discusión y las preguntas que tenemos preparadas para esta mañana. Vamos
no consigo colocar mi imagen porque el host no me permite. Tiene que permitirme poner el video.
¿Podrías ayudar al doctor Arce, por favor? Bien, bueno, podemos empezar de todos modos. Ahí ya está. Excelente, muchas gracias. Muy bien. Vamos a... Sí, yes. Vamos a hacer alguna pregunta, por favor, Tam, adelante.
Yes, for Dr. Carlos Arce. Dr. Arce, which is the difference that you have found between Pentacam and Galileo technology when we are talking about data alignment, especially for toric multifocal IOL calculation?
Well, not because I am consultant of Zimmer, but who is the manufacturer of Galileo.
I have a question here.
Yeah. Well.
Go ahead.
So there was a question, a really good question by Simon. that came in and said, Dr. Fram, what would you do with a referral for 2 years after surgery that had developed dry ARMD and is very unhappy with the trifocal? And we've had a few patients in the practice where we put multifocals in, you live long enough and you can develop ARMD. I had a wonderful interaction with Bob Sinsky when I first started, and I was right out of fellowship, and he said to me, what are the indications for a trifocal or multifocal? And I was ready. I said, perfect cornea, perfect retina. And he said, okay, what happens when they develop ARMD? So I'm very thankful for this question, because I think we all have to be cognizant of the loss of contrast sensitivity that can happen. So in this particular patient, it's 2 years out. I would feel very comfortable removing the lens, but that's only if you understand the techniques of, you know, if the haptics are stuck, you amputate the haptics, as Dr. Maskett showed so beautifully in his videos, that you preserve that capsule, that when you put a secondary monofocal IOL in, you suture it to the iris so that it doesn't move over time, and you give them a definitive final procedure with the caveat that you're working with the retina doctor to see them postoperatively and make sure there's no complications. I wonder what Sam Maskett thinks about all of this.
René, do you want to,
Gracias,
Dr.
Carlos.
Arce,
Si
continue
podría
with
contestar.
your answer? Thank you, Dr. Arce.
Okay. I'm going to answer Pam.
Yes.
I was saying that I rather, not because I am consultant of this company, but for many years, but I rather to have a device that is able to align data to different referential points. The first device to do this was the Orbiscan. Orbiscan was able to align all the data to any place, any referential point in the cornea. Okay, but if I have an alignment to the apex of the cornea, and you can see very well, Nicole used Pentagon. She shows several maps of Pentagon. Okay, you can see in a small box in the bottom at left, when you say, when you see thickness apex is X0, Y0. So the map is aligned to the apex, and you cannot see the apex in the surgical field. Okay, and so what is the apex defined? Apex is defined by everybody as the most anterior point in the cornea in primary position. Okay, so if you have a cornea which is asymmetric, your apex will be here and not here. That's very clear for me. So how the map is done, I don't know. But now with the chord mu and all that is a lot of confusion. And in my opinion, I am sorry, but they are confusing the definition, real definition of apex with vertex or the line of fixation, okay? And the line of fixation is not necessarily the Purkinje. The Purkinje is defined by the reflex in the cornea. Okay, you use, all the systems use a reflex, a coaxial reflex. So if a device has not a reflex recorder, cannot get the Purkinje. Placido topographers get the reflex of the Placido rings. So the center of the Placido rings would be the Purkinje. Also in Galilei, we use 4 dots, and the center of the 4 dots reflected. In the Pentagon axle is totally different than in the Pentagon HR or in the Pentagon simple, because the Pentagon axle copy the 4 dot. So they can have the Purkinje, okay? But if you don't have any kind of reflex, you don't get the Purkinje, and you only are assuming that the line of sight or the fixation during the exam is the Purkinje, and that's not necessarily true.
Thank you. Thank you, Dr. Arce.
Can I make a comment on that?
Yes.
One of the advantages that I spoke about, capsulotomy fixated IOLs, if you can center the capsulotomy on the visual axis, you will always have perfect centration of your IOL if the IOL is capsulotomy fixated. So particularly when it comes to induction of higher order aberrations with diffractive optic or aspheric IOLs, I anticipate there may be some future there.
Yeah, that's very true. That's the reason in my side of examinations, I rather to see the wavefront and the aberrations aligned to different points and not only to fixed point determined by the device. Okay, so that's one feature we have recently. It was not in early Galileis, but now we have that aligned to different points, Purkinje, white to white, pupil, or actually any point, X, Y, you put coordinates and you can align whatever is the IOL alignment.
Muy bien, quiero hacer una pregunta para el doctor Masket sobre, hemos estado analizando sus estudios acerca de las dysphotopsias negativas y sobre el diseño del lente intraocular. ¿Sí me escucha bien?
Dr. Musk.
Okay. Entonces la pregunta es, la captura que hace de la cápsula anterior sobre el lente requiere unas capsulorhexis casi perfecta de 4.9 milímetros para poder hacer un atrapamiento correcto. ¿Considera usted que es un lente diseñado para femtosegundo o puede también utilizarse una capsulorhexis manual? ¿Y cuáles serían sus tips para eso?
The surgeons in Europe who've implanted them have used both what we call a guided capsulotomy, where they've used either rings that are placed on the capsule or an image in the Zeiss Callisto, as an example, projects an image onto the lens surface. That's a guided capsulotomy. And others have used automated capsulotomy primarily by femtosecond laser. There are also other devices that are either on the market or in development. There's a device called the capsule laser that actually fits onto the microscope and in 1 second makes a perfect 5 millimeter or whatever size you choose anterior capsulotomy. Without hesitation, a capsulotomy supported IOL will need the appropriately sized and positioned capsulotomy, hopefully on the visual axis, centered on the axis, and somewhere 4.9, 4.8 or so millimeters in size. But fortunately, again, there are a number of ways that we have at our avail to create that near perfect capsulotomy. Automated would obviously be best in my view.
Adelante, doctor Arce. Adelante, doctor Arce, con su pregunta.
Okay, Dr. Masket, you show it very well that the scotoma is usually temporally inferior, and that a mask with the contact lens can reduce this scotoma because actually you are covering the optics of the light ray. Is something in the cornea that is producing or inducing this kind of a scotoma? Because I began to think that the multifocal channel of, we show in the total corneal power maps, which also is usually temporally inferior, okay, going to more power to the bottom, might be related with negative escotopia. The light rays would cross this kind of channel, and this area will have more power than producing the light rays getting the edge of the IOL. So I would like the probability to correlate those two signs that we show in this webinar now in the future. Maybe you can do that.
Well, my only concern whether the cornea is a participant or not a participant in this phenomenon, I would think then we would be able to see it in phakic individuals. And we only see this in pseudophakic individuals. But the question of whether the cornea is focusing light in a certain area, differentially or asymmetrically, I don't have the answer. You know, none of us have the answer, in fact. So you can develop a theory, but it's, you know, this is a puzzle. Does the cornea participate? There's a study that was just published looking at a variety of factors on intersegment, and I don't think in that particular paper the cornea turns out to be a factor. But take a look at it. It comes from Holland, and it's just in the July issue of the Journal of Cataract and Refractive Surgery. Take a look at that. Maybe there's some more answers there than I'm giving. I'm not sure that I can answer your question about the cornea. I don't believe that the cornea participates, but I can't say that it doesn't.
I have a comment. The contact lens in our studies went on the contralateral eye, so it wasn't on the eye that was actually affected. And that's what showed improvement. Minas Corneal reported on this in 2003 and actually was the first person to come up with the concept of the illumination gap per se. So this, you know, penumbra, things like that. And so he did implicate the cornea as well. So the steepness of the cornea in addition to missing light rays that are hitting the retina.
Is the other eye pseudophakic or phakic?
It doesn't matter.
Doesn't matter.
I mean, we don't have a clear understanding. We think it has to do with summation and other things that are happening in the cortex. It may be a gating issue that many people, most people have some form of negative dysphotopsia, and some people can gate it away and some people can't. That's the neuroadaptation portion to it.
This multifocal channel that I showed happens also in normal corneas, not only in keratoconus, more evident in keratoconus, okay? But usually is bilateral.
Right.
Usually, maybe if it's a cornea participating in this phenomenon, is because both has the same kind of asymmetry, and we should look for that if we have the multifocal channel in both eyes.
Right.
One question for Dr. Masket. Regarding the incidence of negative dysphotopsia, do you think there's an under-registration of the real incidence? That will be the first one. And after,
yes.
How much time after surgery you wait to observe this negative dysphotopsia to disappear, thinking on neuroadaptation and considering the risk that they need to sign up an informed consent before surgery?
I think those are all very good points. With regard to underreported, the paper from Noitz's group from Mahat Kaina that showed that it's 19.6% when asked, it was more than twice as much than when you didn't ask. So if you don't solicit the patient to find out whether they have or don't have some form of dysphotopsia, the incidence will be markedly lower. It's when you ask, specifically ask, when you get up to close to 20%. In terms of time, I encourage patients to wait a minimum of 3 months. We tried to make a 6-month cutoff as to whether it was chronic or not. And at 6 months, we would recommend some type of surgery if they're not able to tolerate it any longer. I still adhere to that, although there are some patients who can push us a little bit harder, but definitely I would not consider doing anything prior to 3 months. What comes up, though, is a discussion about what do you do with the second eye. If it's the first eye, and again, let's say the left eye has a greater incidence. So you operate on the left eye first, the patient has ND, you had them scheduled for surgery a week, 2 or 3 later for the right eye, and now they're coming in with this significant dysphotopsia in the first eye. What do you do? Do you do a different procedure in the second eye, or do you wait? And again, that's where counseling comes into play. As Nicole said, talking to patients teaches you an awful lot. That's how we've learned so much about ND, is primarily by talking to patients. So I wouldn't do anything for 3 months. If they're very symptomatic in the first eye, I may have them wait a few weeks. And if they are still symptomatic, I would do, for the second eye, reverse optic capture as a primary procedure. And we've had 100% success with that as a primary procedure. Not one patient has had ND when we've done primary reverse optic capture, but we don't always know that they would have had ND if we didn't. And then the question about informed consent. I know that a lot of doctors are now considering dysphotopsia as part of their informed consent, because as Olson has told us, it is the chief source of discontent following uncomplicated surgery. And in this project that I'm doing now with the FDA and the manufacturers in Rennes UCLA, we are developing a patient-reported outcome which will become part of the approval process for premium lenses ultimately once we're done with this. So I think without doubt, it should become part of our discussion with patients. It's one of those difficult questions. You don't want to raise the specter of it and make people think about it, but yet they need to know, if it does occur, that they're not crazy and they shouldn't be ignored. And a lot of patients have been referred to us because their surgeon really didn't give them enough sympathy and say, as Nicole does with our multifocal patients, we're going to walk through this together. We'll deal with this as a team. And that's the most important way to deal with any dissatisfied patient.
I have a couple comments. I think, you know, one of the biggest issues is if you operate on a hyperopic patient who you know could have a high angle kappa that's been associated with more ND, you do the first eye, they have ND, they're too scared to move on to the other eye. In that case, you know, you need to help this patient. So 3 months is usually the cutoff on that kind of patient. If we find that a patient says the scotoma is coming and going, that's a good sign that it will go. And so you reassure the patient, but you have to do a good retinal exam and you have to do a visual field to make sure there's nothing else going on. And I think that's an important thing to point out. But just like Dr. Maskett said, reassuring the patient that you know what it is, you have a strategy that can help them. It's not 100%, but you'll do your best, is important. One of the questions that came in was about Bonnie Henderson's study putting the haptics infratemporally. And that study is, you know, is an interesting study. The issue is it wasn't statistically significant after 1 day. So at 1 week and 1 month, it didn't matter. So it may be a good strategy for temporary ND, but it's not necessarily a good strategy for the patients that develop persistent ND. When we talk about reverse optic capture, we need to make sure you understand that you need to put the haptics at 6 and 12, and then you raise the optic on top at the nasal and temporal so you don't get tilt. So that's important. When you're doing primary reverse optic capture, you need to do that with a 3-piece lens. You don't want to do optic capture when the capsule is intact with a 1-piece lens, because you can get capsule block. And so I just wanted to point those things out because sometimes they get overlooked when we're talking about this.
Well,
muy bien. Ustedes demostraron también en sus estudios, ahorita te doy la pregunta, el tiempo, Carlos. En sus estudios publicados, comentan que una técnica exitosa también para reducir la dysphotopsia negativa es el peel-back. ¿Qué criterios o qué lentes seleccionan cuando deciden hacer esa técnica y qué ventajas o desventajas puede tener al compararla con la captura inversa de la cápsula? Esa es la pregunta para ustedes dos, doctor Masket y doctora Fran.
I'm going to pass that baton to Dr. Fram because she would have the same answer I would.
I didn't understand it.
I'm going to ask Nicole to answer that question. I have a one-day post-operative wife, and who had back surgery yesterday, and she really needs me. So with apologies, I'm going to leave now. And I thank you so much for allowing me to participate in this. But she needs me. I'm very sorry.
Oh, go ahead.
Doctor, muy amable, gracias.
Thank you very much.
¿Quiere hacer un comentario final antes de retirarse?
Hasta luego.
Okay. And we wish a good recovery
Adelante,
to your
Nicole.
wife.
Gracias.
I am going to need a translation on that.
Okay. La pregunta otra vez, René, por favor. René.
Sí,
I think.
Bien, ahí va. La pregunta es relacionada en los estudios que hicieron ustedes y que están publicados como estrategias quirúrgicas para reducir la dysphotopsia negativa. Mencionan que se tuvo éxito también con la técnica de peel-back. Entonces, la pregunta sería orientada a que, ¿qué técnica, cómo deciden comparativamente los resultados que tienen con el peel-back contra la técnica de captura inversa de la cápsula? Y en caso de que ustedes o seleccionemos la técnica de peel-back, ¿qué tipo de lente intraocular debemos de seleccionar para poderla llevar a cabo y disminuir la dysphotopsia negativa?
Yeah, these are great questions. So the piggyback technique worked about 73% of the time, and this is consistent with the Sulcaflex data as well. Jay Erie and Simpson have a wonderful paper showing how, can you guys hear me? Yes?
Yes.
Okay. Showing how the piggyback technique works to scatter the light. And so it pushes the posterior optic back and it moves the anterior portion of light being refracted, and that will move the illumination gap. You would expect it to work more consistently than 73% if it was the end-all be-all. And we see with piggyback lenses, you can get chafing and things like that. So we reserve the piggyback technique when we cannot get the IOL out. If they've had pseudoexfoliation in the past, things like that, must have a deep chamber of 3 millimeters. Our preference is to really do reverse optic capture, but sometimes you can't do reverse optic capture if the capsulotomy is too big. Reverse optic capture works 96% of the time as a secondary procedure. But if you can't do it, you have to be prepared to take the lens out of the bag, put an IOL in the sulcus, and we tend to fixate the IOL to the iris. And we use a LI61AO, which is the soft port Bausch & Lomb silicone lens. And the key is to just have an IOL on top of the capsule. But more importantly, moving an IOL more anterior is going to move the illumination gap out of the way of the retina. So our theories about the capsule are there, but really the most effective thing to do is to move the light rays to address the illumination gap issue. So whether you do reverse optic capture a piggyback, nothing is going to be 100%. But a piggyback will cause a lot more iris chafing. We've not seen iris chafing from reverse optic capture positioning. Question?
Yes,
Muchas gracias.
thank you very much. Dr. From,
Tamara?
yes, Dr. From, hello. I would like to know, because I think there is not much data about the smile surgery and cataract. So do you have experience with these patients? And maybe, because I've read an article talking about the masked formula for IOL calculation, if you have some experience with this?
We don't have a lot of experience with SMILE in our practice, and in the US, the penetration is not as strong. So I would defer this question. The masked formula was based on LASIK, and so I don't think you should apply it necessarily because we really don't have the experience. I know in China, they have a lot of experience and would look at that literature. They're doing it on tons of patients. I actually saw the first SMILE technique in India in 2015. So the US, once again, is behind.
Thank you very much.
Muchas gracias por sus respuestas. Queremos terminar ya el webinar. Ha sido un excelente exposiciones. Queremos darles las gracias y quisiéramos únicamente darles el tiempo para si quieren precisar algún comentario o algo que ustedes consideren para cerrar y posteriormente darle el tiempo al doctor Leonel Gutiérrez para que haga el cierre del webinar. Queremos darle las gracias sinceras a cada uno de ustedes y también a Sergio y a Tam que han estado con nosotros al pie del cañón y trabajando muy fuerte. Entonces, adelante, doctor Fran, doctor Arce, si gustan hacer un comentario final, por favor.
Ladies first.
Doctor Fran, primero.
Ladies first.
Thank you. It's an honor to be here. I really enjoyed parts of the pandemic and that I have all these new international friends. And feel free to contact us anytime with any clinical questions. I learned so much today, and I appreciate everything you've done for us to bring our knowledge to the world.
Es un placer para mí poder estar con ustedes en esta oportunidad y solamente me gustaría mencionar que uno de los mensajes sobre mi charla es de que los lentes intraoculares no son como las medias, talla única, y que nosotros debemos tener todas las informaciones necesarias del ojo y de la córnea para poder implantar y escoger el lente mejor para cada ojo. Puede ser inclusive de diferente fabricante, un ojo con el otro. No es muy bueno porque el paciente después pregunta, ¿no? ¿Por qué me puso ese? ¿Por qué me puso el otro? Pero de todas maneras, y esto aquí donde yo trabajo en Brasil es muy importante porque los médicos oftalmólogos incluyen el lente en el costo de la cirugía. ¿Ok? Entonces, puede cobrar más porque es un esférico o porque es un multifocal o porque es un multifocal tórico, más caro todavía. Entonces, tu cirugía, tu procedimiento es mucho más caro que si simplemente usas un lente esférico. No estoy hablando de PMMA, sino solamente un lente flexible esférico. ¿Ok? Yo siempre propongo de que lo que nosotros cobramos es nuestro servicio, nuestra decisión de lo que vamos a colocar para el paciente, cuál es la prótesis que se va a colocar en el paciente, porque los convenios o seguros médicos nos pagan por biometría, no nos pagan por selección del lente intraocular. ¿Cuál es el mejor lente? Entonces, En relación a esto, nosotros debemos pensar en la cobranza de nuestro servicio y no del producto que nos lo vendieron más caro. Por lo tanto, si yo escojo un esférico, para mí es lo mismo, el mismo precio que el asférico. No será el mismo precio que el multifocal porque lamentablemente ya el diferencial de costo aquí en Brasil entre un multifocal o un multifocal tórico es mucho, mucho mayor. Pero mi guía del costo de mi cirugía está con el asférico. Y el esférico lo cobro igual, porque yo lo estoy colocando y yo lo estoy seleccionando porque es el mejor lente para ese paciente. Los exámenes podrán tal vez un día llegar a descubrir si el ojo tiene alguna predisposición para la dysphotopsia negativa. Espero que sí. Muchas gracias a ustedes por esta oportunidad y espero poder estar en otras oportunidades también. En español, que es mi lengua nativa.
Muchas gracias, doctor Arce.
Antes de darle tiempo al doctor Leonel Gutiérrez, nada más recordarles, al finalizar las charlas, va a aparecer el examen para que ustedes puedan resolverlo, y en caso de que no sea así, llegará el día de mañana un correo electrónico a sus correos con una liga para el examen, el cual contestarán y será suficiente para acreditar los puntos del consejo. Muy bien, muchas gracias a todos, sinceramente. Y el tiempo es para el doctor Leonel Gutiérrez Mendívil para que pueda hacer la clausura del webinar.
Agradecerles a nombre de los integrantes del Colegio de Oftalmólogos de Sonora la participación, el doctor Carlos Guillermo Arce, te agradecemos mucho, te mandó muchos saludos el doctor Solón Serpa, me dice que nos platicó que eres originario de Perú, nos decía el doctor, sí, ¿verdad? Dice, curiosamente, pues te mandó muchos saludos, estuvimos con él en un excelente webinar hace unos días atrás. Agradecemos mucho, doctor Carlos Guillermo Arce, su participación, al doctor Masket, que se tuvo que retirar, sabíamos que tenía un compromiso, recién acaban de operar a su esposa, a la doctora Nicole Fram, le agradecemos mucho su participación también, y a nuestros compañeros, a la doctora Tamara Montenegro, que le invirtió mucho tiempo, estuvimos en el chat ahí, estos últimos 2 o 3 días, ahí estaba viendo el chat diario, mañana, tarde y noche. Sabemos que estás en Francia, doctora, y a veces desvelándote diferentes horarios. Al doctor Sergio Ruiz Smejaut, un excelente compañero, te agradecemos mucho tu participación, nos ayudaste bastante aquí en la elaboración de este proyecto que nació de una idea de nuestro amigo Abraham René Liera, un inquieto socio aquí de nuestro colegio que nos metió en este proyecto con un gran problema ahí para la cuestión de la interpretación. Ya vieron, pues el intérprete no es oftalmólogo, entonces con ciertas dificultades ahí, pero bueno, pues salimos adelante, gracias al ingeniero Marco Antonio Suárez, que es el que nos ayuda mucho con esta plataforma. Y bueno, este webinar queda grabado en el canal del colegio, en el YouTube, en donde se puede consultar después. Va a quedar esta excelente charlas, van a quedar ahí para poderlas consultar con más calma. Y pues mil gracias a todos los asistentes por haber estado acá con nosotros. Todavía están 196 todavía sentados, y les decimos que en las próximas 24 a mayor 48 horas les llegará un examen, encuesta a sus correos donde se registraron, y la plataforma de Zoom nos arroja los archivos, quiénes estuvieron, cuánto tiempo estuvieron conectados. Toda esa información la mandamos al Consejo Mexicano, y el Consejo ya les dará los puntos para la recertificación. No me queda pues más que agradecerles, y no sé, algún otro comentario más, sino ya para dar por terminado este excelente webinar.
Gracias a todos, nada más.
Bien.
Muy bien. Adelante, gracias,
Bien,
Sergio, Tamara, Carlos, muy amable.
Muy bien, doctora Tamara, bien. Gracias, Sergio Ruiz. Carlos Arce. Bien.
Thank you. Excellent.
Buenas
Gracias,
tardes y
Nicole. Gracias, Nicole.
Excelente.
Gracias.
cuídense mucho.
Bye, bye.
Sí, Mario, muchas gracias.
Bye. Gracias, Mario.
Marco Antonio, perfecto.
Así, órale, vamos. Bye.
Bye. Muy bien, René.